This is John Goldblum. Today I'm going to be talking about one of my favorite topics, and that's Barrett's esophagus and Barrett's related dysplasia. In fact, this is our most common consult on our GI consult service. So clearly it causes a problem for practicing pathologists. Definitely causes a problem for myself and my colleagues. And to tell you the truth, we meet every day at noon and have a consensus conference, and one of the more common types of cases we show in that consensus conference is the presence or absence of dysplasia in Barrett's esophagus. And sometimes we agree and sometimes we don't, and that's the nature of the problem. So this is where I work at the Cleveland Clinic. I've been here for 25 years, and as I mentioned, I practice GI pathology as well as soft tissue pathology, and a good portion of my time is spent looking at GI biopsies from Cleveland Clinic physicians, but also GI consults from pathologists all over the United States. And again, one of the most common types of consults that we see is exactly what I'm going to be talking about today. So really what I want to tackle, number one, is to clarify the definition of Barrett's esophagus. If you're watching this in the United States, there's a definite agreed upon definition of Barrett's esophagus in the United States, but that doesn't necessarily pertain to the entire world. We have a tendency in the United States to think that what we're doing is adopted by the entire world, but that's not the case, particularly when it comes to Barrett's esophagus. I'll spend a short amount of time talking about some of the pitfalls in the histologic diagnosis of Barrett's esophagus. There's only a couple. The big problem is really recognizing dysplasia in Barrett's and using this as a marker of increased cancer risk for this disease. And then finally, I just want to talk a little bit about some of the newer options for treating the upper end of the spectrum, high-grade dysplasia and beyond. This is an esophagectomy specimen. We don't see these very often, and I won't go into the great detail of this case, but the bottom line is this patient had a long-standing history of Barrett's esophagus and was followed with endoscopic surveillance biopsies. And unfortunately, there was a set of biopsies that were read as indefinite for dysplasia by one pathologist and as intramucosal adenocarcinoma by another pathologist. So that's quite a discrepancy, ranging from indefinite to intramucosal adeno, and clearly they went with the diagnosis of intramucosal adenocarcinoma because you can see this resection specimen. This is the Barrett segment, but notice there's no obvious gross lesion here. It's not a big fungating mass, and what we have to do is put this whole thing under glass and look for the cancer that was diagnosed preoperatively. And in fact, in this case, a submucosal invasive cancer was detected.